Good evening, good afternoon, good morning, and welcome to the Family Planning 2020 Asia Budget Advocacy Strategic Exchange webinar. My name is Martin Smith. I'm the Managing Director here at FP 2020, and I'll be your moderator for a very packed 75 minutes coming right up. To remind everyone, this webinar is being recorded. It will be on our website later, of course. And if you have questions or comments throughout the webinar, please do put them into the chat box. We will collect those and make sure all of those questions are asked. We have a question and open answer session, which will start in just about 40 minutes from now, but we will collect all of those questions. So just a few opening remarks from myself before introducing you to the structure and the speakers of today's webinar. Unlocking resources and cultivating sustainable revenue streams for family planning is a core element of the FP 2020 agenda and, of course, central to our collective work and action together. Successful advocacy to secure those revenue streams requires critical skills and skills that we can learn from each other and learn from each other's success. The financial landscape for family planning, as we all know, is evolving really very swiftly. While donor funding is still important in some contexts in the region, in Asia, an increasing number of countries are seeking and securing domestic resources. Several countries in this region are now very largely funded from domestic sources, as we reported in our progress report last year. We all note the significant momentum around universal health coverage, orientated efforts and mechanisms, and a potential shift of resources away from vertical funding models towards broader investments in health systems and integrated service delivery. And so against this backdrop, this webinar is intended to share critical global, Asia regional and country insights. And we have three key objectives. Firstly, to build our knowledge of domestic resource flows and how family planning is financed, including through UHC country packages. Secondly, to share best practices, including the use of costed implementation plans and other tools and approaches to mobilize resources for family planning. And thirdly, to learn about successful budget advocacy strategies, both in terms of data and messaging, that are used to influence family planning budget allocation, especially at the sub-national level. And we have five wonderful speakers for you. We have Elisha Dunn-Georgios, the Vice President of Programs at PAI. We have Mervyn Christian, Program Officer at Advanced Family Planning. We have a double act from India, Jay Pratibha and Monica Wahangbam, who are the Health Economists at Population Foundation of India, who are obviously part of Advanced Family Planning. We have Chi Valido, the Director of Programs and Advocacy at the Forum for Family Planning and Development from the Philippines. And last but by no means least, one of our newest commitment-making countries, Nurgul Smankolova, the National Program Analyst on Reproductive Health at UNFPA in the Kyrgyz Republic, will be joining us. And just to correct, Jay Pratibha is a health economist at the Population Foundation of India, and Monica, a program coordinator at Advanced Family Planning in India. We have given each of these speakers 8 minutes, fully 8 minutes. Doesn't sound like much, but they have worked very hard for a highly impactful 3 to 4 slide presentation to give you those key messages. We will move through each of those speakers, and then we will arrive, as I say, in about 40 minutes from now, at a key question and answer session where we will be taking all of those great questions, which I know you're going to be typing in to the chat box, which is part of the software for this webinar. And so without further ado, let's move into hear from our first speaker, to hear from Elisha Dunn-Georgios from PAI. Elisha oversees the programmatic work of PAI and has more than 15 years of experience in the fields of sexual and reproductive health and international development. She currently supports several PAI initiatives, including engaging country-level advocates as constructive partners to government-led universal health coverage efforts, as well as an initiative for government accountability for family planning budgets. Elisha, we're really, really happy to have you with us today. And over to you for your 8 minutes. Thank you so much. And Elisha, can you hear me okay?
Yeah, can you hear me?
Yes, thank you. Thanks very much for bearing with us. So please.
Okay, so we're all set. Sorry about that. I think technology problems early in the morning in the US. So thanks very much. I'm going to give a short, as Martin said, 8 minutes. And I just wanted to talk a little bit about sort of an overview of the UHC landscape and where we're seeing advocacy opportunities. So PAI has been engaged in the UHC movement for quite a few years now, really because we saw the opportunity for family planning and also saw that our country partners and in-country colleagues were sort of struggling with how to figure out UHC as a mechanism. And so most recently, we've been tracing and monitoring health policy and systems reforms at the country level and really looking at what the advocacy opportunities are within these changing systems, in addition to work that we've been doing at the global level to advance primary healthcare and family planning within the larger UHC SDG landscape. So can we go to the next slide, please? Oh, can you click through to the animation? Thanks. So I just wanted to put this up as a reminder of the SDG target around universal health coverage, something that we're probably all quite familiar with by now. And luckily, everyone reaffirmed the commitment to achieving this by 2030 recently at the UN high-level meeting. So I think what's important here, though, is to remind us all that the underpinnings of this target are about equity, access, and quality, and financial protection. And I think, of course, the financial piece is what we'll spend the bulk of today talking about. But it's a good indicator that there are many parts to UHC, and it's not just one thing that needs to be changed. But particularly, the financial protection piece, that's the key of UHC, really necessitates major change and strengthening of health systems and financing at the country level. And really, in simple terms, when we talk about health finances at the country level and in sort of the global context, we're really talking about 4 different methods of health financing: out-of-pocket payments, health insurance, government financing, and external sources or donors. And ideally, where the sort of global movement has landed is what we want to see, and particularly as it comes to family planning. We would like to see a decrease in out-of-pocket payments and an increase in coverage through health insurance and other mechanisms, and an increase in domestic resource mobilization and government financing, and a decrease in external donor funding. That's a huge shift from where we are now, especially for family planning. Can we go to the next slide? So I want to just pick up a little bit on the health insurance piece and attainment of UHC. I think this is sort of where the global buzz is around creating national health insurance schemes, and where we hear a lot of talk about benefits packages and making sure that essential health services are included in benefits packages and figuring out a way to cost these out at the country level. There's been a lot of different global figures floating around about what per capita expenditure should be on a health package, and also what needs to be included. I think it's really important for the global community to recognize that because these decisions are going to be impacted at the country level, and that's where programs are implemented, we really need to look and partner with countries to work through this and see what benefit packages each country can afford and what's needed based on the population. The piece of national health insurance, or the many pieces that are so important and striking when it comes to UHC, is that there's a real opportunity within these new sort of creations of national health insurance schemes in terms of strengthening the health system and delivering quality services. I think there's also a place here in advocacy opportunities for really increasing investment in preventative services, which of course should include family planning and reproductive health services. And as part of this, you'd want to see as well a real expansion of the government stewardship role, not just seeing the government as a provider of public health services, but also really engaging in government system reform as a whole to make UHC work in country and expand access, equity, and quality. Again, those real underpinnings so that we have some improved health outcomes for marginalized populations that haven't been a part of the process so far. But how do we do that? I think if we go to the next slide, the health financing decision-making process is pretty complicated, and I think for organizations, regardless of health sector, but from what PI has seen, particularly family planning and reproductive health organizations, we're not really being actively consulted. I mean, I can say at the global level, and maybe colleagues from AFP and FP 2020 would agree with this, but we've kind of had to marshal our way into the global conversation around UHC to make sure that family planning and reproductive health remain a priority within that dialogue. And we see the same thing at the country level, that CSOs aren't really actively being consulted, and often the health financing decisions and discussions are happening in those separate circles of health economics or ministries of finance that CSOs don't necessarily connect with. What we've heard from and have seen from our grantees and partners in country is that often they're sort of put off by what are highly technical discussions about capitation and pooled marketing and taxation, things that reproductive health and family planning service delivery providers or advocacy organizations don't normally engage in. And so there's also this real need then to build capacity to help CSOs come to the table and talk in a sort of economic way about cost-effective analysis rather than I think where we often start out as a group, which is around human rights and quality of health and life. That doesn't necessarily have as much interest in the health financing world as it should. Next slide, please. Next slide. Oh.
And Elisha, I'm sorry if we have that as our final slide, but
okay.
But please,
no problem.
Please continue to make your points. No problem. As we stay on this slide.
No problem at all. So, you know, looking at these sort of four pieces of the decision-making process, it's important to note that although it can seem sort of daunting and difficult to overcome, there really are opportunities for advocacy in this process of developing benefits packages and health insurance schemes. And with a little bit more understanding of the process and sort of who the key stakeholders are involved at both the global and the country level, there are places to influence. So benefits package, of course, is the one, and we talk about this all the time recently, especially coming out of the UN high-level meeting and even before that, following on the Astana Primary Healthcare Conference, because it's so key that family planning be included in a benefits package to really reduce those out-of-pocket payments that we spoke of earlier, as well as reduce external funding for family planning and get government to mobilize domestic resources to cover that expense. It's also really important to note that benefits packages aren't the only place where advocacy is needed. And particularly when we're talking about family planning or other reproductive health technologies, we can't forget that the regulatory frame and work in a country is equally important in terms of introducing new methods of contraception and making sure that there is a really diverse method mix, as well as allowing for new technologies to come in as the universal health coverage grows over the years. And on that point, I would just say that, you know, UHC is a dynamic system. So that means that it's not sort of one and done. Yes, we want to get family planning into the benefits package, and we want to make sure that there's quality care and access and equity across the board from the beginning. but there needs to be ongoing accountability and monitoring of the system to make sure that it continuously meets the needs of the population. And that is a really, really important place for CSOs to continue to work with governments and service delivery organizations to make sure that UHC isn't a static entity. And so the last place, and I think we sometimes forget about this, but the ongoing accountability of governments and others engaged in UHC at both the global and the country level is sort of really where we need to focus over the long term. Right. And so I'll stop there because I think my 8 minutes is probably up.
Perfectly,
you're welcome.
perfectly
Looking forward to questions.
Thank you very much, Elisha. Perfectly timed, and we're getting questions in, of course. And Elisha, I'm going to come back to you in the Q&A, and I know that colleagues on the line are intrigued to hear your further reflections on how we can best support country-level advocates as effective partners within government UHC efforts. So we'll come back to you on that question, and indeed on others in just about 30 minutes from now. Thanks, Elisha. So we're going to move on, and we're going to move on to the next slide. And it's my great pleasure to introduce Mervyn Christian from Advanced Family Planning. Mervyn's based in Baltimore, where he supports in-country partners in Bangladesh, India, and Indonesia to implement the AFP's advocacy approach. His background includes country-level support surrounding community mobilization, behavior change communication, capacity building, and advocacy. And Mervyn, great to hear from you for some insights on budget advocacy towards UHC from within the Asia region. So over to you.
Thank you, Martin. Good morning and good afternoon or good evening to all our participants. Can you hear me? Okay.
Yeah. You broke up at the beginning, but now you're coming in loud and clear. Thanks.
Okay, great. Thank you so much. So thanks for this opportunity to FP 2020. And, I can already see some of our partners and champions from different countries participating here. So it's good to always have familiar, names and faces in the presentation. So just a quick note, Advanced Family Planning is an advocacy initiative, and it's funded by the Bill and Melinda Gates Foundation, the David and Lucille Beckett Foundation, and the William and Flora Hewlett Foundation. Next slide, please. Yeah. And I won't delve a lot into this, but want to kind of focus on our goal that which is to increase financial investment and political commitment to support the FP 2020 initiative and ensure access to voluntary high quality family planning. And we have our objectives listed over here. Most of our work that we do in countries, we focus through a unique approach, which is called the SMART approach. Well, the SMART terminology is in existence since the 1980s, but we've adapted it, and you can find more on our website on how we develop a strategy, how we develop an advocacy strategy using the SMART approach. The Advanced Family Planning is an initiative that's active in 8 countries at the moment, and we continuously advocate at different levels. Mostly our work is focused at the subnational level, where devolution has and decentralization has occurred. Next slide, please. So while some of this is true for all the countries that we work in, our strategy in Asia, and some of these are also learnings from our work in Asia. In the 3 countries that we work in, as Martin has mentioned, which is Bangladesh, Indonesia, and India. We primarily work through partners and local champions. So in all the countries that we work in, we have 4 focused partners, and they partner with other colleagues and champions in their own countries and geographies. So our primary approach has been to mobilize local champions. We form the advocacy working groups, and our colleagues from Population Foundation of India will delve more into this, what the advocacy working groups are. But it is basically what we do is to gather local champions from different backgrounds who have been working in family planning, and also those that are not working in family planning. And we provide them with resources, tools, and platforms that accelerate the rate of achievement and move the issues that we want to resolve more faster than earlier thought, because it is bringing in the power of many together. Our work in Asia is also focused not on increasing overall family planning budget, because in the three countries that we work in, family planning, and just a quick background on that, is that these countries, specifically India and Indonesia, are not donor dependent. They are, except for Bangladesh, um, they are all committed to Family Planning 2020 initiative, and family planning within each of these countries is a focus programs, and they have their costed implementation plans that they follow to allocate funds and resources to family planning. And policies in all of these countries that we work in are favorable to family planning. I would say largely are favorable to family planning. Of course, there are policies that require improvement and amendments, and most of our work is focused at the subnational level where decentralization has occurred. So I would say that for Indonesia and India. In Bangladesh, our work is focused more at the national level. However, we've found opportunities to work at the subnational level in Bangladesh as well. So I lost the slides. Can we go back to the previous slide? Sorry, thank you. So our work is focused, funding in the three countries that we work in for family planning isn't an issue. It's the spending that's an issue. It's the translation of policy into action that's an issue. So our work is focused on identifying those policies and activities within those policies that require funding to have those policies implemented. So the advocacy is focused on that. And if but what I mean by that, so I'm going to take an example from India, and thinking about the family planning program, a lot of the funding in India, the family planning program, is focused on sterilization, and by that I mean incentives for sterilization. But a lot of other activities and other policies that are family planning related do not get adequate funding. So the work of partners and these local advocacy champions has been to translate, identify those activities, and advocate for funding for those activities. We are, of course, from the very beginning, we are very opportunistic to identify those opportunities that are low hanging fruit, and we are intentional about impact from the very get-go. So what I mean by that is we identify by taking different activities or objectives from the start, and is thinking whether it's worth our time, whether it will deliver enough impact to achieve the goals and the objectives that we have outlined. We build adaptability from the start. So the SMART approach is a very decision maker centric tool. So if a decision maker changes, the advocacy strategy changes. Sometimes we also have to drop the advocacy objective is not very favorable to certain objectives. We focus on innovations, and again, I'll bring in the local advocacy working groups, because a lot of national policies do not get translated into action at the subnational level because the strategy does not work. It's not adapted at the local level. So the local advocacy working groups help in bringing innovations to adapt the national policies so that they can be implemented. We replicate best practices, so we don't always reinvent the wheel. We take strategies from different countries and different geographies and share with the geographies that we are working in, and implement and advocate for their replication, and mobilize more funds. And we engage with non-traditional partners. So by that I mean we've engaged with companies and corporations to allocate more funding for family planning. We've engaged with non-health departments of the government and brought in champions for family planning from those departments. So largely overall combined together, has been our strategy for family planning. Next slide, please. And like I said, our budget advocacy is focused largely on translating policy into action and identifying certain activities within each of those policies. And here are some examples from 3 different countries that are focused on specific things within each of those, within the family planning program and specific policies that have been outlined to raise money for family planning. So while these are smaller examples, it may seem that, okay, this is one example from each country, but what does this all account to, bringing them together? So we recently, as we wrap up our India program, we did a calculation of how much money since the last 5 years that we've been working in India has been mobilized for family planning through the advanced family planning effort. Can you go to the next slide, please? So here's a collective of how much money has so far been mobilized for family planning. And we're talking about a country where the family planning program is well funded, not always well spent. But even when the program is funded, there are so many opportunities to mobilize more funding. And by focusing on translating policies into action, we can raise more funding. Next slide, please. I think I'll end over here and wait for questions. Thank you.
Thanks so much, Mervyn. Wonderful to then start talking about the Asia context and some great insights from India, Bangladesh, and Indonesia there. Laid some nice groundwork for our conversation about India in just one moment. So Mervyn, we're going to take some questions through the chat box that will come to you on later. I know that those questions are likely to center around the functioning of these local advocacy working groups, and then some of the fascinating insights you gave on how we're engaging non-traditional partners, the private sector, corporations, and other parts of the government beyond health. So stand by for those questions. As we move into our third in a sequence of our 5 speakers now, and it's great to introduce Pratibha and Monica, who join us from India, where the AFP smart advocacy approach that Mervyn laid out has led to impressive family planning budgetary achievements at the national and at the subnational, at the state level and the district level. Their advocacy work has highlighted the cost benefits of investing in the health of women and children, as well as to the increased gains towards achieving the demographic dividend. So over to you, Pratibha and Monica, and great to hear more context on India. Thanks so much.
Thanks, Martin. This is Pratibha, and good afternoon, good evening to everybody present in this discussion. So let me quickly tell you, this is a joint presentation by me and Monica. I'll briefly present some of the challenges in allocation and spending family planning budgets at the national level, while Monica will take you all through a successful budget advocacy model at the decentralized level that enabled additional resource mobilization for family planning activities. So, well, as the previous speaker Mervyn said, in recent years, the family planning budgets have increased substantially in absolute terms, which is very welcome move on the government's side, because clearly indicates the government is walking the talk on its commitments, both national and at the international level. So while we look at the family planning budgetary allocations, like when we go and analyze deeply, we find that the budgetary allocations are not in alignment with our demographic needs. Most 70%, close to 70% of the budgets that are allocated going for permanent methods of family planning, and another 10% of the budgets again goes in as incentives for sterilization of like incentives for sterilization, mobilization for frontline health workers. And barely 3 to 4% of the budgets are allocated for spacing methods, where India has a large youth population, close to 232 million, who require more of spacing methods. And another important challenge in the budgeting is there is absolutely very less money that is being allocated for capacity building of providers on newer methods of contraceptives that are introduced very recently into the family planning basket, and also on on activities that can bring in behavior change to generate more uptake of services. And more critical issue that given this allocation, a more critical issue that we have is in terms of spending the allocated budgets. Like we find that more than 40% of the budgets remain unutilized, and again, the money that is spent is mostly directed for limiting as well as incentives to frontline health workers. Some of the issues that are there inherent in the system, which largely there is inadequate capacity for budgeting at the decentralized level. There are delays in approvals and fund release from the center to the states, down towards districts and implementing agencies, further downwards. Lack of integration of different accounting systems resulting in poor tracking of expenditures, and above all, there is a huge shortfall of human resources. So with this, I'll quickly transfer this presentation to Monica. Monica?
Yes, thank you so much. Yeah. Thank you for this opportunity. In the next, can I have the next slide? Yes, thank you. In the next few minutes, I'm going to talk about budget advocacy at the district level through the mechanism of the Family Planning District Working Group. The working group is a multi-sectoral convergence advocacy group at the district level. It is chaired by the district magistrate, who holds the highest administrative authority in the district. And in some districts, we also have the chief medical officer who heads the health department. Since the working group has been formed to strengthen the family planning landscape in the district, it has a large representation from the health department. Having said that, since it's a convergence model, it also has representatives from various other government departments like education, social welfare, livelihood, the local self-government, and also private providers, medical associations, and representatives from the civil society. PFI has successfully formed and also operationalized 18 district working group in Bihar and Uttar Pradesh. Next slide, please. Now, coming quickly to what processes were followed for budget advocacy, enabling to see some very encouraging outcomes. PFI's role is limited to facilitating the working group meetings using the AFP SMART approach. In the interest of time, I'm not getting into the details of what the AFP SMART approach is, but what we typically do is we support the working group to identify issues or gaps related to family planning in the district. A large part of the facilitation is supported and also guided by the landscape assessment that PFI along with the district health department would have already done prior to the meeting. The facilitation helps the working group to develop, district-specific short-term objectives as well as strategies. PFI's one major role is in identifying the funds required for addressing the gaps and issues, and in the facilitation with input from the working group members, wherever possible. We also try to identify funding sources within the district. Based on all of these inputs together, a detailed work plan, including the budget, is developed, which is then endorsed by the district magistrate. Once the plan is in place, what we have realized is that the district is very confident in taking the programmatic aspects forward. However, for the budget advocacy, we support them with messages using evidence so that the working group is able to engage in effective budget advocacy for the funds required. Next slide, please. Oh, no, sorry. So what has this advocacy by the working group in the 18 district led to? Between 2015 and 2019, the working group has been able to effectively leverage almost 3.9 million USD, which is, I believe, a good figure, Of this total fund leverage, a larger part of almost 3.7 million USD is fund allocated for the first time for family planning. The second level of fund leverage of approx 173,000, while it may sound small in terms of figure, but the availability of this fund has helped the district in many ways, and therefore is very significant. The availability of this fund has, from various sources within the district, has actually enabled strengthening of almost 1,500 facilities in the 18 districts in the last 4 years. What it has also enabled is it enabled the training or refresher training of providers, especially on IUDs and injectables, orientation of outreach workers, setting up of counseling corners and the training of the counselors, purchase of equipment, and many more activities, the budget for which is not allocated in the budget. This fund is also significant because enabling all of these activities that I just mentioned now is leading to improved quality of family planning service provision, improved method mix, expansion of service provision, and also very importantly, improving access by enabling family planning service provision to reach closer to the community. Last slide, please. Yeah. So I want to share a few lessons learned from my experience on budget advocacy. The first is budget advocacy requires building a very strong confidence of the district officials, as it requires for them to share not just details of fund allocation, but also details of expenditure, and more importantly, the challenges related to budgeting and fund expenditure. It takes time, but once we are able to show how budget outcomes help in program improvement, the next level is actually not difficult, and that has been one of our big learning. Contrary to the belief that many have on the effectiveness of convergence model, our experience in the 18 districts clearly gives us to believe that that the convergence model is not only effective, is effective not only for policy advocacy, but equally for budget advocacy as well. Coming to my last point, for sustainability, we really believe that it is crucial to build the capacity, the skills of the district manager within the system to not just understand budget advocacy, but also to be able to see how effective budget outcomes will support district in changing the overall family planning landscape. Yes, and that's the end. Thank you.
Thanks very much indeed, Monica and Pratibha. Excellent presentation, and questions are coming in. Please continue to put them into the chat box within the software. We're going to share all of these presentations with you afterwards as well, of course, but get those questions in. We're going into Q&A in about 20 minutes. And Monica and Pratibha, I think one question that you can ponder on for us to get to the Q&A is, if you had a chance to start this budget advocacy all over again, what would you do differently? Very good question for you to think about now as we move through to hear from the Philippines and then the Kyrgyz Republic. So our next speaker, Chi Valido from the Philippines, will be sharing reflections on adolescent reproductive health advocacy in a country, the Philippines, that has faced significant family planning policy barriers, including a temporary restraining order on contraceptive implants back in 2015 that we all remember very well, and we remember how that was overcome. Now, Chi's work in the Philippines has led to increased capacity, collaboration, and budgetary support in sexual and reproductive health. This is a critical area for our collective focus, and Chi, we're really fascinated to get your insights from the Philippines today. So over to you.
Okay, thank you so much, Martin. Can anybody hear me okay?
Very loud and
clear. Hello? Okay, so hello everyone. I'm honored to be part of this learning session. I'm from an NGO in the Philippines called The Forum, and we do parallel advocacy work for policy and budget at the national and local levels. We are part of two large NGO consortia. One is called the Reproductive Health Advocacy Network. So this is alliance in the forefront of the campaign for the passage of RH law, and it continuously addresses any legal and anti-RH challenges with our law. And another consortium is the Alternative Budget Initiative, or ABI. ABI is an alliance within an alliance because it is composed of 3 NGO groups focused on budget advocacy work at the national level in 3 areas or clusters: health, environment, and education. The forum is part of the health cluster. So since 2006, even before we had a reproductive health law, ABI had been engaging government and Congress to help ensure that there is appropriate and efficient budget support for health programs in the country. But for this session, I'll be talking about our experience at the local level, in particular a project in Cebu City. So next slide, please. So in the Philippines, as Martin said, about 500 teenage girls give birth every day, or at least 24 births by teenagers every hour. The Philippines is one of 7 countries globally with more than 25% increase in HIV incidence in the past decade. Currently, there are 38 new cases of HIV in the country, with more than 70% of those new infections are young people. But the Philippines operates under a devolved system since the passage of our local government code in 1991. It took us 14 years to pass our RH law, but budget support for the implementation of the RH program is still under the national agencies, such as the Health Department and the Commission on Population. Implementation of the RH law was also off to a slow start because of many legal impediments and petitions to the Supreme Court that were only recently been resolved. So these legal battles affected the allocation of annual national budget for RH. There are also other challenges at the local level, one of which is priority setting. Health versus other local development concerns, and then there's role of the accurate data, what data which affects how we can advocate for the prioritization of RH and the plans of our local our local government units. While there's insufficient budget at the national level, we had to use our laws to find the money and funding mandated by law. We had to make the laws work for us. One example is the village level allocation. That's why when we advocate to our local legislators and local chief executives, we had to remind them of the current RH situation using the national and local data, and then the budget mandated by administrative orders and other policies. Next slide. Okay, I would just like to explain the illustration in this slide through the story of our project in Cebu City. So this slide illustrates how our Youth Council Reform Act helps ensure the youth participation and involvement in governance with mandatory budget allocation. Halfway through 2015, we received a grant from FP 2020 through the Rapid Response Mechanism for our proposal to provide ARH information and training to night high schools in Cebu City. Cebu City is one of the biggest cities in the country with 81 villages. The city has the highest rate of teen pregnancy in the country and has among the highest rate of new HIV infections. And you can imagine if you're a night student, you're really in the margins. So at that time, they had 29 night high schools catering to 30,000 students. So classes starts from 6 to 9 p.m. on weekdays and 8 a.m. to 4 p.m. on Saturdays. This means that when the city and all its service agencies, including local NGOs, are ending their day, these students' day is just beginning. So students come from among the poorest in the country. So after our grant because our grant was so limited, we had to focus on how we wanted to make sure that after we left, we don't just leave them with just education and training for the teachers. We want to make sure that all adolescents, not just our adolescents and youth from the night high school in general, will be able to have access to reproductive health services. So we had to find the money from what our current law provides. One strategy is to really work with the City Local Youth Development Office. So this is the office under the Office of the Mayor. The office was also tasked by the Mayor to assist the villages of the city in their annual work plans and the utilization of the youth program budget, which is 10% of the internal revenue allocation per village. By this time, we didn't have yet the elections for the Youth Council, which happened in May 2018. So by the time our project ended, so we had an opportunity to really improve this approach. Now going back to the drawing, in May 2018, after the suspension of elections for more than 5 years, we had the village and youth council elections. So we had 41,000 barangays or villages, which also includes youth representatives from each village. under this is a law in the country. So which means that under this law, there's already a mandated budget of 10% from the internal revenue allocation of each barangay. So this was an opportunity for us to really ensure that there's budget for our age. But there's also, but this law also helps scale up the 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 participation of young people from the municipality to the province, because each village leader can have a representative in the municipality, and the municipality can have they'll elect their federation representative to be part of the provincial board, which means that they are equal to any other councillor with this with powers and duties of each councillors and provincial board member, including all the budget allocations that can be provided to them. But at the same, but more importantly, I think the opportunity for them to introduce ordinances that will help sustain adolescent and reproductive health programs in their villages, municipalities, and province. So next slide, please. So in our project, this was the approach that we did, and we're trying to continue that. At the end of the project in Cebu in 2017, the project became a catalyst to engage local policymakers and decision makers to make stronger commitment to improve the state of our age, not just for our night high school students, but also for all young people in Cebu City. The project was able to help advocate for a budget for our age, including HIV and AIDS, for 2 million, which is, you know, it's quite small, $40,000, but they didn't have any budget before. So ARH was also integrated in the youth development program activities, such as the inclusion of ARH learning sessions during their annual youth camp. The budget for RH was further increased in 2018 to 7 million. Since our village elections in late 2018 and this year 2019, we're continuing village level engagements to our youth leaders. So we're conducting a lot of mapping of our leaders in our project areas. We're doing policy write-shops to them. We're trying to make them understand the law. We're trying to provide them with what our current data situation is for reproductive health. And actually, I'm in one of our project sites right now, following up on our post policy write-shop training, and they've already reported to us that they've already filed ordinances that they've crafted during our workshop. So this is the approach that we're doing now. I think a key message, and I think in this presentation, is that while we are doing a lot of advocacy work for budget at the national level, we have to take a look at what we have at the moment. What are we have to examine what we've lost that we have. We have to find the money where it is. But doing parallel advocacy at the national and local levels as well. So I guess that's it, and just wait for questions from the participants.
Thanks very much indeed, Chi. Excellent, and lovely to see some of this initial success, the elections happening and allocations starting. I know that there'll be questions surrounding how the law has enabled budget increases and what you foresee, not only in Cebu City but for other parts of the Philippines as well. I'm sure questions will center around there, and we're going to get to those questions in just about eight or so minutes time. But before we go to those questions, it's great for me to welcome Nurgul Smankulova from UNFPA in the Kyrgyz Republic. Nurgul has been supporting the significant efforts surrounding family planning's budget advocacy towards meeting the country's ambitious FP 2020 financial commitment made in 2018, and that commitment was to increase public funding to ensure a reliable supply of family planning commodities, particularly for vulnerable segments of the population in the Kyrgyz Republic. So Nurgul, over to you. Thank you so much for joining us today.
Yeah, good morning. Can you hear me?
Yes, beautifully clear, Nurgul.
Yeah, thank you for opportunity to be in this webinar and to also to learn from other experience. And I'm glad to share our practice about successful budget advocacy strategy used to influence a family planning budget allocation, especially at the centralized national level within the Ministry of Health. So next slide, please. So Kyrgyzstan is characterized by the rapid population growth with a total fertility of the 4 children per woman. And the country has the highest maternal mortality in the Eastern Europe and Central Asia, where the CPR, contraceptive prevalence rate, was decreased for the last 10 years. And then unmet need for family planning has sharply increased from 12% in 1997 to 90% in 2018. So there are several challenges. So for instance, in the past, funds for contraceptive provided by the government were procurement through the UNFPA funds. But unfortunately, such support was stopped in 2015. And the available range of the modern contraceptive in the country is scarce, and the contraceptive are expensive, especially in the remote area in the region, due to the limited of the price regulation and out of reach for the vulnerable group of the population. And additionally, there were a lack of the capacity and expertise of the program budget formulation with its execution among the key health policy decision makers. Additionally, not only key health policy decision makers, but also the civil society organization were not engaged more well with the budget process. There was still a huge challenges, especially in regards to participations and openness of the health budget. Failure by the Ministry of Health to facilitate civil society involvement in the budget process had amounted to violation of the rights of the participations. Moreover, lack of publicly available information on health budget issues had seriously hindered the efforts of civil society organizations, which attempted to participate in the debate of the use of the public resource. So on the right side, you will see that in 2018, the government of the Kyrgyz Republic joined the Family Planning 2020 movement, making Kyrgyz Republic willingness to family planning in order to ensure reliable supply and reasonable use of contraceptive for vulnerable segment of female population. So Ministry of Health pledged to allocate state budget for contraceptive and increase funding annually for health system. For instance, in 2019, at least for 1 million soul, which is amount additional $50,000 in comparison with previous year for women from the list of high medical and social risk of maternal mortality. What does it mean, the list of the high of medical and social risk of maternal mortality? Because due to the limited health budget, Ministry of Health concentrated to the challenges related to inequality. And Ministry of Health understood that women of reproductive age who had high risk of maternal mortality rate in society were often most dependent on the public health system. But they often lack any say in this decision. Thus, the financial commitment referred to the list of women from the medical and social risk, social area, who might be risk to the maternal mortality. A list of women at risk who needed free contraceptive was prepared and analyzed finding requirement for the procurement of contraceptive. So the list includes women with social risks, such as disabilities and specific medical risk group, which might be risk of maternal mortalities. For instance, epilepsy, mental disorders, cardiovascular, respiratory disease, diabetes, cancer, tuberculosis, drug, alcohol addiction, HIV/AIDS, and kidney diseases. There were around 155,000 women at high risk of maternal mortality in the country. Moreover, active member of Public Health Council is our partner who can look at allocation, expenditure tracking, and the budget health, which was crucial for us to develop critical evidence of reproductive rights efforts and to advocate for necessary budget-related steps to be taken for better realization of human rights. So, and finally, UNFPA also with Ministry of Health and with civil society need to work to increase the range of the contraceptive. And the UNFPA, with UNFPA support, Ministry of Health work to increase the range of the contraceptive available in the list of the essential medicine of the country, so that women can have access to contraceptive of their choice. As a result of this work, more contraceptives are available in the list of essential medicine. such as the ID Cupero, Depo-Provera injection, and right now the implant will be in the process to register, which can allow to pass the custom clearance and available in the pharmacy. So the next slide, please.
Okay,
next slide, please. Yeah, can you hear me?
Yeah. So we're on to the outcomes and key lessons. Is that where you want to be?
No, can you back for the advocacy?
Yeah,
yes, for the successful advocacy approach. What was advocacy successful approach used to be influence family planning budget allocation. So high-level policy discussions through the numerous meetings with the Member of Parliament's Minister of Health, Finance, and other key decision makers have taken place to bring about the policy change in support to women from vulnerable groups. And UNFPA with Minister of Health used data and evidence of the benefits of family planning for vulnerable women groups to advocate for state budgetary allocation for the procurement of contraceptives. The data of family planning and strong evidence-based materials were provided for key policy decision making that can be used for advocacy of the budget. So, for instance, by 2090, the size of the population had reached 6.3 million, which was 1.5 million of women of reproductive age. However, contraceptive coverage at most at-risk women of reproductive age in the country, in general, remained low, who has potential risk of maternal and perinatal mortality. So, Ministry of Health developed a 5-year plan to gradually increase public funding to meet the needs of women in the high medical social risk of maternal mortality by 2023. The plan includes financial resources needed in the next 5 years to cover the needs of these women. So, a 5-year plan is expected to be a key instrument for the government in planning for the health budget of the contraceptive and advocated among partners to support the planning program budget performance improvement. So I do hope that 5-year plan will serve till 2023 as an opportunity to develop sound advocacy strategy to measure progress towards financial sustainability. What else? Mass media was sensitized and encouraged to write articles and video materials with key advocacy message in support of allocation of funds for contraceptive. For instance, civil society prepared the advocacy message that Minister of Health should use the budget to effectively realize women's rights, that need to understand the relationship between the budget to human rights guarantee in constitutions and reproductive rights law, which is ratified in 2015. And finally, as a result of the consistent advocacy efforts by UNFPA and the Ministry of Health, for the first time since independence in 1991, has allocated funds in amount of 3.2 million sums for the procurement of contraceptive in 2018, and secured budget of 4 million sums for 2019. So, by the way, just 1 month ago, Ministry of Health has procurement contraceptive for 2019. Next slide, please. Let me also highlight what are the outcome and key lessons learned. So we will have challenges such as the health budget for 2020 may remain the same in the amount from the previous year due to the limited national health budget. So therefore, the current efforts should be sustained and expanded, and not to lose these current gains. And even the Ministry of Health took a huge step forward in addressing the needs of women of reproductive age by taking financial commitment to family planning for the last 2 years and allocated some modest funds for contraceptive. However, these funds were integrated in the budget line related to all medicine provided by the Ministry of Health. As there is a need to separate budget line, which is because there is no ring fencing mechanism to ensure that the budget for family planning is utilized for this purpose, to track the expenditure, monitoring, and utilization of this fund. So country office will continue support to building capacity of key policy decision makers and civil society by focusing on the budgets and financial management, which one of the key strategies to increase the reliability of funding for procurement contraceptive. This strategy included proposal to create sustained separate budget line for contraceptive and ensure greater protection of these funds with the public budget, and to ensure compliance with the budgetary procedure, and to guarantee that funds is available on a timely basis and can be utilized, used, and monitored rapidly. So, and additionally, we need to engage the private sector as a partner to have the new advocacy people who can be advocate this public-private partnership. And finally, the Parliament dedication to family planning will be continued, but without continuous support from the civil society, particularly the state budget line and the tracking and spending of the budget, the public health council attention and the Parliament attention may be diverted to other areas. So the Ministry of Health Advocacy will continue to work occurs throughout the budget cycle, seeking to influence budget formulation, make the budget accessible to women at high risk of maternal mortality. Once it has been formulated in 2020, a track whether the family planning budget is implemented as planned. So 3 stages of the budget process will be interlinked. Planning, the first, second, formulation and budget monitoring, and finally, control execution. And each builds on and strengthens the next strategy. Thank you very much for your attention.
Nurgul, thank you so much for those great insights on the Kyrgyz Republic, and questions are coming in. And I've got a question for each of the 6 of you. And thank you very much for these great questions. And we've probably got about just under 15 minutes to go. So I think these sound achievable, as long as our answers are succinct and pithy and to the point, if that's okay, dear speakers. So a question first for Elisha, if that's okay. 2-part question for you, Elisha. Firstly, how do we strengthen civil society organization engagement in these country-level health financing dialogues, part 1? And secondly, are there any examples of best practices from PAI country partners in this regard? Over to you, Elisha.
Okay, thanks very much. And I just want to say it was great to hear all of the presentations and hear about all of the great and impressive work, and I know what are some very difficult contexts. So for the first, I'm actually going to answer the second one. We have done some work in Zambia that we have written up in a case study, which I can, Martin, maybe you guys can share that afterwards. Absolutely. Because it really walks through the process of how Zambian family planning reproductive health CSOs mobilized at an opportunistic moment in Zambia's process of developing their national health insurance to really get a seat at the table and beef up their own knowledge about UHC and the sort of economic speak around UHC that was really helpful for them in creating a partnership with the government officials working on that process. So if we can share that afterwards, I think that as a practice will really help some people understand the process. I think I just, for the first piece, I think there's a couple of things that I noticed and heard in the presentations that might be helpful for this. I mean, one is, you know, again, like we're very used to, in traditional budget advocacy, working in our family planning silo. And I think UHC presents a real opportunity, but also a challenge on that front. That the health financing conversation may become a little more holistic. And this is very dependent on country context. So I can't make a blanket statement on this. But I think that there is a chance here to further all of the good budget advocacy work that's been done around creating family planning budgets and making sure there are allocations, and now looking at expenditures, But there's also a chance that the sort of quick movement of countries to national health insurance and UHC coverage could really muddy those waters. And I think it's really incumbent then upon us as CSOs who've been working so hard to ensure that there's domestic funding for family planning to understand how the movement around UHC in country impacts what gains have already been made. And Mervyn, of course, mentioned the AFP SMART approach, and that is a great way to start to get into that and start looking at that as an objective and really thinking about who key stakeholders are at the government level that CSOs should be partnering with and talking with to help further the advocacy. And on that point, I just want to say too, around transparency, I mean, it's probably no secret that it can be very difficult to get clear information and documented information from governments, often because governments wrongly see CSOs as troublemakers rather than what we really could be, which is partners in helping move forward an agenda. And again, really thinking through a SMART approach and mapping out who the decision makers are and stakeholders are and starting to build productive relationships can help move that forward. But I don't want to minimize the sort of big piece that transparency issues can cause. And then finally, just a thought about something coming out of the Philippines presentation. It's important to keep in mind that UHC is an opportunity, but it's not a panacea. And so if you are working in a country that has a very restrictive policy environment around family planning and reproductive health, there's a real push here that needs to happen to make sure that UHC addresses that policy environment rather than enshrines the restrictiveness into its framework. You know, if adolescents are restricted now, having UHC and national health insurance doesn't automatically erase that. And so again, like I talked before about not only financing, but really thinking about the regulatory environment that UHC is coming into, and also the policy environment. I mean, those dialogues still need to happen. It's not all about financing. And so there are other ways that CSOs can engage in UHC without it being just about budgets.
Thanks very much, Elisha. Very, very good broadening point at the end there. It's not just about the money. So we move on. And great question here for Monica from PFI. Monica, were there examples of meaningfully including youth representatives in these district working groups that you spoke about, similar to the system that we heard about from Chi in the Philippines? Over to you, Monica.
Yeah, thank you for that question. Unfortunately, we do not have youth representative in any of the 18 working groups, but focusing on the young population has always been on the agenda of the working group. So, you know, the working group developed these strategies which focused on young people, and one of the example I can give is the government of Uttar Pradesh approved and also allocated almost 280,000 USD for setting up of youth clubs in 40 colleges across UP, and at the same time also strengthening 10 public health facilities to be able to provide adolescent-friendly health services to these young people. So there are a couple of other examples also focused on young people, but we do not have youth representatives as of now, but we feel that that is something that needs to be there.
We need to work towards. Thank you. Thank you very much indeed, Monica. And a second question quickly to India. I guess this should go to Pratibha maybe, or to both of you. We saw significant amount allocated to family planning for limited methods in your presentation. This is a question from Jadikshwar in Nepal. He said, in Nepal, fertilities reached 2.3. The government is not easily convinced to invest in family planning at this stage. So his question is, what different approaches have been applied to convince policymakers or district government authorities to form these working groups and to allocate these family planning budgets? There's some similarity between the Nepal and India contexts, of course. So over to you, Pratibha, or Monica would like to answer that one.
Yeah, Monica, I'll take that.
Okay, great.
Yeah, so in India, it actually took time for us to convince the government to start the working group. However, Indonesia already had successfully implemented the working group, which we used for our advocacy. But what really clicked is at the ICFP meeting at Bali, we had the decision maker from both Bihar and UP, and we were able to organize a cross-learning meeting with the Indonesia District Working Group and the partners, and I think that's what really clicked. And post that, it really went very fast. We started the district working group in 4 districts initially, and once we started getting the outcomes, and because we focus on short-term outcomes, it enabled us to expand the working group in additional 14 districts. So yes, it was not easy, but I think 3 main factors: learning, cross-learning, and also evidence from other programs in other countries actually help to set things moving.
Thanks so much. Great insights from India on those questions. So going to move over to Chi here. Before then, I'm moving to Mervyn and then to Nurgul. So Chi, a couple of interrelated questions for you. Firstly, how did the SK representatives manage to get the same powers as the provincial board members? How did those young people get those powers? Is it in fact mandated by law? And what is the procedure for selecting those youth reps? I'll give that to you first, and then a quick question about the money second. But I'll let you answer on that one first.
Okay. I hope everyone got the paper I sent earlier. Yes, It is a law. In our local government code in the past, there's already a provision for a youth council representative. But in the past, the youth council representative was the children of the politicians. And the 10% budget allocation for youth program, it wasn't clear how it's going to be used. So it's often used for pageants and sports fest. So on July 2, 2015, we had the Youth Council Reform Act. So under this act, the age for anyone who wants to be part of the council, you have to be a registered voter, age 18 to 24, to run for either a youth council chair or as a councillor in the village. And you have to win the election, of course, by registered youth voters ages 15 to 30. So once elected in your village, you automatically become a councillor. So the youth council chair automatically has the Committee on Youth and Sports Development. So that's why I said that they have equal powers as any other councillor. Well, each village forms a municipality. So each village, through their youth council chair, is part of the municipal federation of youth councillors. And from this group, they elect their federation youth federation chair. And the youth federation chair, once elected by their peers, becomes a member of the municipal council. And the same process is done at the provincial level when of all the municipality youth councillors elect their provincial level representative, who then becomes a member of the board. So under this process, the 10% budget allocation for youth program is still there, but this time the new law specifies that there should be 9 areas of participation that they will spend it on. It cannot be used for infrastructure. It can be used for activities that support youth development, which includes health. That's why in our advocacy, we try to engage our youth counselor to make them see what's the local RH situation in your village, in your municipality, in your province, so that we can help them prioritize how they're going to come up with the policies for their village and municipality, but at the same time help them prioritize adolescent reproductive health.
Right. And actually, in your answer, you also answered the second question from Roddy, who's, I think, in the Philippines, which is about how that 10% is prioritized, the areas that it's going to be focused on. So thank you so much, Chi. So moving over here, a couple of interrelated questions, one for Mervyn and one for Nurgul, around non-traditional partners in the private sector. So firstly to you, Mervyn, we heard from you about engaging non-traditional partners. Would be great to hear some examples from a couple of countries, or from one of the two countries that we haven't heard from Bangladesh or from Indonesia, on how non-traditional partners are being engaged, and some tips from you on how advocates in country can go about doing that. Then I'll move on to talk to Nurgul about engaging the private sector in the Kyrgyz Republic. So over to you first, Mervyn.
Sure. So we have a couple examples that are coming in from Bangladesh, where the partners are involving the fishing companies who are in the remote locations where family planning access is limited, and they are engaging the fishing companies there to promote and provide family planning services.
Thanks very much, Mervyn. And just on to Nurgul now. So Nurgul, you were mentioning about the private sector. Oh, sorry, Mervyn. I'm sorry. You were still speaking.
It's okay. You can continue. Maybe I can answer after Nurgul.
No, I don't want to cut you off. I thought it was a short answer, and in fact, it was because your sound cut out. So can you repeat the second part of what you said? Because I don't think everyone caught it, Mervyn.
No, I think that the strategic approach that works when involving non-traditional partners is the policy environment in country and the priority that family planning program has in country. And that's worked for Bangladesh and also for India, because India also has a private sector policy that requires a 2% contribution to corporate social responsibility. In Bangladesh, we are kind of taking the benefit and advantage of the priority that family planning program has in country, and we are using that as a key strategic approach when going to corporations to invest in family planning.
Thanks so much, Mervyn. So over to you, Nurgul, and I realize we're slightly over time, but that's because the presentations and the questions have all been so wonderful. So final question for you, Nurgul. Part of your work, engaging stakeholders and decision makers includes working with businesses and the private sector as part of a total market approach in the Kyrgyz Republic. The question here is, what lessons learned do you have for engaging the private sector in budget advocacy and in your overall efforts to increase financing for family planning in Kyrgyzstan?
Yeah, thank you very much for these questions. So we used total market approach to address the funding of contraceptive. The first area, the people who is rich, who can be used out of the via pocket, which can use to go to the pharmacy by themselves and to use the pocket for the pharmacy. The second people, the people for the insurance woman. So this insurance woman within the state benefit guarantee package, a benefit from accessing discount contraceptive with the state guarantee benefit package. So we have close collaborate with the private partnership that we need to advocate the contraceptive that will be benefit for accessing this discount contraceptive price. And collaboration of UNFPA with mandatory health insurance fund has resulted in increased number of prescription for contraceptive for insurance women. And finally, which is the people from the state budget. From the state budget, we used only for the centralized Ministry of Health budget. So we have three areas. One of the much more people who can use their pocket, one of the insurance women who can use the state benefit guarantee package, additional drug package, and to work with a pharmacy company to use this opportunity with discount price. And the final for centralized of the Ministry of Health, which is using the state budget. And we have the, right now we engage the public-private partnership to much more have much more registered the contraceptive, which was included in the essential medicine list. And as for the non-traditional parties, as you mentioned about, we also engage the faith-based organization, Can you hear me?
You're still coming through clearly. We heard faith-based organization. Please carry on.
Yeah, we work with the faith-based organization. We have several of the tools, family planning in Islam, and the stepping stones how to be step by step to work with the community to open to discuss SRH issues. And this Ministry of Health also this year, for instance, we had the World Contraception Day, which also we work with the closely work with the civil society and faith-based organization to promote family planning among community, including youth. So, for instance, in 2017, UNFPA supported the development of the health toolkit for students and for madrash, which is an integral part of the reproductive health and well-being of adolescents and youth. Currently, this toolkit has been integrated with all madrash, the madrasa in total classes per year. In addition, UNFPA has stepping stone for religious leaders with supplementary brochure of safe motherhood, STI, HIV, and family planning for youth. And as I mentioned before, that this year, State Committee of Religious Affairs and Muftiat and civil society organization organized meeting with religious women and men to raise awareness about the family planning methods and contraceptive use in Islam. This initiative was dedicated to celebrate the World Contraception Day, and this continues such as initiative due to the positive support from key stakeholders in the near future.
Great. Thank you so much, Nurgul, and thank you to all of our speakers. Great question and answer session. So just a few quick closing remarks from me. Firstly, the speakers mentioned spending is a challenge. This point about only sort of 40% of the allocated budget remain unspent in India. And my colleague Mande Limbu has reminded us all that FP 2020 plans to organize another virtual exchange in the next few months that will focus specifically on tracking expenditures from allocation to expenditure and supporting accountability efforts in that regard. That will come hard on the heels of the publication of our progress report, where we will publish domestic family planning expenditures and progress on FP 2020 commitments. So thank you very much for that reminder, Mande. So it falls to me to thank all of our speakers most profusely for your great presentations, to Elisha, to Mervyn, to Pratibha and Monica, Chi and Nurgul. Thank you so much for joining us today and for sharing your insights. I'd also like to thank all of my colleagues here at FP 2020, Mande Limbu, Faith Tabifor, Chonghee Huang, for their considerable efforts to put together this great webinar today in coordination with our speakers. I'd like to remind everyone that a recording of this webinar will be available very swiftly on our website, and that materials will be shared with all of you, I think including some follow-up materials such as the Zambia example that Elisha referred to in the Q&A just now. And finally, your views. We are in a consultation phase in thinking about the family planning movement beyond 2020. And we invite you all to go to familyplanning2020.org/beyond2020 to leave your comments on the draft vision framework that does indeed incorporate thinking around financing, around family planning within universal health coverage. Please give us your views. They're critically important. That consultation phase is open through until December the 1st, but please get your comments in early. So with that, I'd like to thank everyone very much for your time. Enjoy the rest of your evening, afternoon, or morning if you're just getting started, and we'll be in touch with you very soon indeed. Good day.
Thank you, Martin.
Thank you.
Thank you.